Good morning, everybody. Two things. A, can you hear me? B, can you see my screen? Just a quick yes will do, just so I know I'm not talking to myself. Okay, well, I'm going to assume you can hear me and you can see my screen, so let's hope you can. So we're going to talk about fluids in critical care, and fluids are actually a more complicated subject than you would imagine. But hopefully, what I teach you now will help you understand some of the processes we go through when giving patients intravenous fluids, and also understand why we stop giving intravenous fluids. How do I get this to go forward? I don't know. Hold on a second. This is a PDF. I've no idea how to get it to go forward. Let's try there. There we go. Okay. So worked it out. So what you've got to remember is that fluid is a drug, and we are trying to balance between perfusing the patient's organs, so that's the benefit they may or may not get from fluids, and not give them tissue edema, which is the toxic side of it. So you can see on the scales there. And you know, a lot of our patients, they end up really boggy, with lots of edema, making them very difficult to cannulate, amongst other things, and not very pleasant for the patient as well, especially when we're trying to move them. Of course, that edema is not just in their skin, that edema is present elsewhere. So the four rights of fluid stewardship really are about the right drug. So we need to understand the difference between crystalloids and colloids, the right dose. So what is the bolus volume and the speed of that bolus? And we don't always get that right. The right duration, so when to stop. So by that I mean not when to stop the fluid bolus, but when to stop giving fluid boluses, because there will come a point where they actually don't make any difference anymore. And then the right patient. So we need to make sure that we are giving the right fluids to the right patient, depending on their hemodynamics. So first of all, let's talk about the body fluid compartments. 60% of what you weigh is water. I know. Amazing, isn't it? We're just a big bag of water, really. But that's divided into several different compartments, and there's really only one of those that we've got direct access to. So we've got intracellular fluid, so fluid that is within the cells themselves. That's two-thirds of that 60% is in the cells. Extracellular fluid, that's a third. So you've got fluid that is outside of the cells. And that fluid outside of the cells is made up of interstitial fluid and intravascular fluid. So interstitial fluid is any fluid basically that is not within the cells and is not within the blood supply. So, think of the alveoli in the lungs and the blood supply that goes past them. There's obviously something else in the lungs as well in between those, and that's the interstitial space. Okay. So the intravascular space only comprises 25% of the one-third of extracellular fluid. So, and that's the only compartment we can directly access. We can't directly access any of the others. And importantly, only 25% of an isotonic crystalloid bolus remains intravascular after redistribution. And we'll talk about tonicity in a little while. It's a bit of a tricky one to get your head round. So if you think you give her a litre of fluid, 750 mils of that is going to go anywhere and everywhere except the intravascular space. So not much of it is actually going to stay in the circulation. It's going to go to all those other places it can go to. So you can see why our patients end up looking like Michelin Man. Looking at sepsis, and sepsis is one of the things where our patients' cellular membranes and vascular membranes become leaky. And you may have heard of the glycocalyx membrane. This is a lining within the vascular walls, which when it is intact, stops a lot of that fluid from moving. But sepsis degrades that glycocalyx and the cell walls break down. So you get this capillary leak in sepsis and shock. Fluid can move out of the intravascular spaces into the interstitial spaces more easily. And this is what we call capillary leak. So if we give them loads and loads and loads of fluid that they don't actually need, it's got nowhere else to go except into the interstitium and then into all the other places that may cause harm. So let's talk about osmolarity versus tonicity. Okay. So you may have heard of isotonic, hypotonic, and hypertonic. So think of an isotonic solution as if you were pouring fluid onto a tiled floor. The tiled floor is not going to absorb any of that fluid. It's going to stay within the circulation. It's not going to get absorbed by the cells. You're not going to have these fluid shifts, and it's the fluid shifts that are really important. If you look at the one above, hypotonic saline, now imagine we're pouring fluid onto a carpet. That carpet will absorb a lot of that fluid, and think of the carpet as the cell. It would just absorb all that fluid, which causes cell swelling. And the hypotonic solutions, as you can see, is D5W, is dextrosaline. It's the American terminology for it. And 0.45% normal saline. The normal saline we give is 0.9% normal saline. So there's not a great deal of difference in the salt content in that saline as compared to the cells. If there were, then salt would move one way or the other, and what always follows salt is water. And then you get a hypertonic saline. So this has got a high salt content, and in order to make that high salt content the same as in the cells, because the body wants to balance the salt content, it's going to draw a lot of the water out of the cell to make what's out of the cell less concentrated. You've still got the same amount of salt, but now you've got more fluid in there. So it's like a glass of squash. If you have a lot of squash at the bottom of your glass and you fill it up with water, you're going to make that squash less concentrated. The more water you put in, the less concentrated your squash will be. And that's what a hypertonic solution is doing. So it's taking water out of the cells. And then an example of that would be 3% normal saline. It's got a lot more salt in it. It's a hard one to grasp, and I still forget which is which. So what's the common things we give to our patients? Well, commonly on ITU, we give balanced crystalloids. And for us, the Americans again call these lactated ringers, but we call it Hartmann's. Or they're given normal saline, so the 0.9% sodium chloride. And occasionally we'll give them plasma, won't we? The sodium content of human plasma is 140 millimoles. The chloride content is 100 and the pH is 7.4. So this is what's in your blood. This is normal human plasma. So you can see that the normal saline has got 154 millimoles of sodium and 154 millimoles of chloride. Now, the chloride content is very high in a normal saline, so if you give them too much, you can give them something called hyperchloremic metabolic acidosis. The movement of that chloride within the cells can cause the patient to become acidotic. And you can see as well that the pH of normal saline is 5.5. It's an acidic solution. So if you give a patient too much normal saline, you can create an acidosis just through that process alone, which is why we don't give much normal saline in intensive care. Our patients are struggling with acidosis anyway, and there are good reasons for giving normal saline, which we'll cover later, but they're acidic anyway. You don't want to be pouring more and more acidic solution into the patient. And compare those with the balanced crystalloids, the Hartmann's. So the sodium in that is 130 to 140, more like plasma. The chloride, 98 to 109, more like plasma. And the pH, 6.5 to 7.4. So the pros of Hartmann's, it's more physiologic. It's more like what we have in our bloodstream. You get reduced acute kidney injury, stroke death in sepsis, and there's trials that have shown this. You avoid it in severe brain injury because it can cause swelling. The normal saline is neurosafe and it's cheap. One of the reasons you use it. But like I said, we can get this hyperchloremic metabolic acidosis and it can cause renal vasoconstriction as well, causing the patient more kidney issues than they started with, which we don't want to do. So that's why we use a lot of Hartmann's. And that's why when I go to the wards and I see patients who are septic having saline poured into them, I'll change it for Hartmann's because we're not doing them any favors. So talking about the hypotonic and the hypertonic, there are particular indications for using these solutions. So if you've got somebody who is hypernatremic, you can use hypotonic saline to try and drag some of that sodium back into the cells because you want that hypernatremia to be reduced. So you want that salt back in the cells rather than in the circulation. Again, we don't use it very often. If you go to the guidelines for hypernatremia, it is one of the recommendations of the Endocrine Society, I believe. But you have to be very careful because if you infuse it rapidly, you're going to cause cerebral edema. The cells are just going to get full and full and full of fluid. With the hypertonic saline, again, we don't see it used very often, probably see it more used in neuro. This is the 3% normal saline. That high salt content drags a lot of fluid out of the cells and into the circulation. It can be used in severe hyponatremia, where the salt levels are low and you're trying to get the salt back into the circulation, or cerebral edema. So you're trying to reduce the amount of pressure on the brain. Again, you have to be careful. This is why when we correct people's sodium levels, we do it carefully, especially, especially the hypertonic, the hyponatremic patient. You have to correct it really careful because you risk something called osmotic demyelination. So you're going to be stripping the nerve cells of their coating, which helps them function if you correct it too fast. Colloids. Colloids is something that we use very occasionally. There's lots of debate about the use of colloids. There is some argument that using too much colloids can lead to earlier acute kidney injury. But the point of a colloid, what is the point of a colloid? Okay, we give fluid to take fluid off the patient. How does that make any sense? Right, you've got large molecules in albumin traveling through the bloodstream. So what then happens is that because you've got large molecules, big supply of large molecules, the concentration of those molecules is higher in the circulation than it is in the interstitial spaces. Hemostasis doesn't like higher concentrations of anything. It tries to equalize them all the time. So what it will do, it will draw fluid from the interstitial spaces into the vascular supply, thereby leveling out the concentration, but also drawing fluid from the interstitial spaces into the blood supply. And this is why we often give colloids to patients who are very edematous. We're trying to suck that fluid out of the interstitial spaces and back into the blood. Albumin is the commonly used one. We'll often give it in septic shock after large crystalloid volumes, or if the patient's cirrhotic. If they're cirrhotic, they've got a lot of fluid, a lot of fluid in their tummy, which we need to get out because it's causing them all kinds of problems. So we'll give them albumin to try and draw that fluid back into the circulation, and hopefully then they'll pee it out. We used to use something called starches. We don't use them anymore. They're very much contraindicated. There's a known increased risk of kidney injury and bleeding. And again, there's been trials done on those. So you won't see starches used anymore. We used to use something called hetastarch, I think it was called, or pentastarch. Don't use them anymore. So what are we trying to achieve with giving fluid? It's something called the ROSE concept. So that's resuscitation, optimization, stabilization, and evacuation. So we're going to pour fluid in, aren't we, to try and save the patient's life, to correct the shock, to make sure that the organs are being supplied with blood, basically. You're trying to get that blood pressure up to make sure that they get supplied with the necessary oxygen and all the rest of it. Pour fluid in. Once we've done that, we then optimize it. So we're going to give a bit of fluid here, a bit of fluid there. We're going to do something called passive leg raises, which we don't do very often in an IITU, but maybe we need to get better at that. And we'll talk about the passive leg raise in a moment. Then you get to the stabilization stage. So now your patient's blood pressure has settled down, your vasopressors aren't going up and up and up, and hopefully they might actually be coming down by now. So we don't want to be giving them any more fluid because that fluid is now probably doing more harm than good. We're aiming for a zero balance. And then eventually, once we're confident that the patient's blood pressure is good and they're perhaps off their vasopressors now, that we can start the evacuation phase. We can do de-resuscitation. We're going to remove the excess fluid. That's where you see us giving patients frusemide or, putting them on a negative balance on the filter. The reason we're doing that is because we need to take all that fluid out that we've poured in so the patient can get better. So what are the 5 R's of fluid prescription? You need to define the indication for every bag. So you want the right fluid for the right patient. So resuscitation, immediate shock management. That's one of the indications. Okay, we need to give them fluid because their blood pressure is down in their boots, and we need to support it until we can start getting them better. Routine maintenance, daily needs for nil by mouth patients. We have to be careful with this, with routine maintenance, because again, if you give too much, it's going in the wrong spaces. So you need to decide what their losses might be. And the standard I work from is 1 ml per kilo per hour. So if I've got a 70 kilo patient, we want maintenance, I'll prescribe them 70 mils an hour. Probably Hartmann's, but maybe we need to start thinking of things like dextrosaline with a little bit of potassium as well. They get the sugar, they get the potassium replacement, and they're getting water as well. or replacement, correcting deficits. So if they've got a very active bowel, or their NG tube is draining loads and loads, then we need to replace that as well, and we need to work it out. Redistribution, so managing third spacing. So this third spacing basically is what I'm talking about with things like albumin. So the fluid is now moved into the patient's gut with a cirrhotic patient, not into their gut, but into the peritoneum, into that space. Their guts are swimming around in all this fluid. We give them albumin to try and draw that fluid back out. And then we need to reassess. So we need to be sure that is the patient stable now? Are we overloading them? Then maybe we shouldn't be giving them fluids anymore. So the great debate, saline versus balance. So these balanced crystalloids again, Hartmann's. There's lots of arguments about when we should be using these, but you'll see this mainly used in ITU. So the studies all say preferred for sepsis, diabetic ketoacidosis, and general critical care. The evidence for that is the SMART and the SALT ED trials, and the benefits are reduced major adverse kidney events and death. Normal saline is the standard for a traumatic brain injury. Balanced fluids are slightly hypotonic and may increase intracranial pressure. So that's why we don't give Hartmann's to the brain injured patient. But there is a risk in sepsis of hyperchloremic acidosis and renal injury, as I said earlier. So should we be more liberal with our fluids, or should we be more restrictive with our fluids? Now, what you can see on that side is the famous Starling curve. So this is about preload is essentially how much fluid you're giving to your patient. So if you load your patient with lots and lots of fluid into their ventricle, it stretches and stretches and stretches. The more stretch you get, the better the cardiac output you get to a point. So you can see as we increase preload, the cardiac output improves. Eventually, it won't improve any further. You can only stretch that ventricle so far. So now if you start giving them more fluid, you're not actually improving their cardiac output. You're pouring that fluid to some mysterious place where the patient doesn't need it. So are they fluid unresponsive? And there was two recent trials, Clovers and Classic, which showed that restrictive strategies, i.e. going to vasopressors early, are safe and reduce edema. So we should be using something like the passive leg raise. So basically, in its weakest form, you're literally lifting the patient's ankles up into the air and seeing if there's a rise in their blood pressure. More formally, it should be done with, head tilt and all the rest of it. And you should be monitoring their cardiac output actively using something like the LiDCO. But, I've done it and I see people do it all the time, just lift the legs into the air. I'm not sure that's the best way of doing it, but that's something else I'm looking into. But the important key point there is that only 50% of hemodynamically unstable patients respond to fluids. So if you give them fluid, they don't respond, they need pressors because there's nowhere else you can go. Giving them fluids is not making any difference. You're pouring it into all the wrong spaces, and we're going to have to get all that off at some point should they survive. The consequences are multiple as well of fluid overload. You give them too much fluid, you create pulmonary edema, you prolong their ventilation. What's wrong with my throat today? You increase renal congestion, too much fluid in there, an acute kidney injury. And their gut will also be edematous. So if they've got an edematous gut, they're not absorbing. Or if they are absorbing, they're not absorbing well. So we need to go then to the de-resuscitation strategy, the evacuation phase. You want to achieve a negative balance. So we do that with diuretics and we do it with filtration, which you see all the time on our patients, don't you? We're aiming negative today. So what's the bedside algorithm? Is the patient in shock? No. Okay. So maintenance, only if they're nil by mouth. Otherwise, they don't need any fluid. Don't give them any fluid. You might want to assess their responsiveness with a passive leg raise. If they're responsive, you give a bolus. If they're non-responsive, you start vasopressors. So is patient in shock? Yes. Check. Is it traumatic brain injury? No. Use Hartmann's. Yes. Use normal saline. And again, assess their responsiveness. If they are responsive, more fluid, another bolus. But later on, is the patient stable but edematous? Yes. We need to get that fluid off. Now's the time. So the core principles of stewardship. 1, respect the drug. Fluids have indications and toxicities, as I've mentioned. Try and understand the difference between isotonic, hypertonic, and hypotonic. You could explain it to me then. Know the compartments. Most fluid do not stay in the vessels. They go into the cells, interstitial spaces, all those other places that we don't really want the fluids to go to. The phase matters. So are we in early resuscitation, in which case we can give more fluids, again, testing the response, or are we restricting them later on because we're in the evacuation phase now? We need to get the fluids off. And that's printed twice for some reason. Didn't notice that. Okay, so tailor the fluid. Balance for sepsis, saline for the brain. And then de-resuscitate, prevent the third hit of organ edema. You don't want your patients getting edematous because it's not just their skin that gets edematous. Everything gets edematous with the impacts it has. Okay, so that's just a very quick fly through fluids. Like I say, has been recorded. It will go on the critical care education website, web page, intranet page, I think we call it. I am slowly putting them on. The last 4 or 5 are on there now. If you don't know where that is, just get one of the PD nurses to let you know where it is and how you can find it. Must admit, I struggled to find it, so maybe you do too. I hope that's been helpful. And Ruth, I thought you were meant to be in bed. Clearly not. Okay. Stop the share. Stop the share. Now, somebody just assure me that you could hear and see all that, please.